today I want to talk about waiver of consent. When could we waive the consent? Now, since one of the criteria for waiving the consent is that the research needs to be no more than minimal risk. And that's one of the criteria for waiving the consent. There are other criteria that we'll talk about, but since minimal risk is one of the criteria for waiving the consent, I think we need to, well, I want to first talk about, what do we mean by minimal risk? How do we define that so that we're all on the same page? Now, having said that, different countries define it somewhat differently, though the general concern or the general agreement is that it's low risk. But how do you determine low risk? And one, for sure, at the very least, would want, at the very least, every country to have a consistent definition of low risk, because you don't want one IRB in one city defining low risk differently from IRBs in other cities in the same country. So let's see how we could get on the same page on what we mean by low risk. And the first thing, if everyone could turn on their videos, that would be helpful in trying to replicate the face-to-face. I know it seems like Sarah just got into the car, but as long as you don't go more than 100 miles an hour, I think we could tolerate that. Okay. All right. So the first thing I want to do is this exercise. One of the definitions of low risk is to link it towards common procedures done clinically. So just to get an idea of what, also there will be many different procedures done in a protocol, and we want to see how consistent we are in ranking the same procedures in similar ways in reference to the risk level. So I have here some common procedures done in the clinic, and we have three choices to rate these procedures as less than or equal to minimal risk. Even before I give you a definition of what minimal risk is, let's see how we are as a group. So these procedures could either be less than or equal to minimal risk, greater than a minor increase above minimal risk, meaning that it's not minimal risk, but it's slightly above minimal risk. And it's important to get that out, because the regulations for children, at least in the US, has this phrase, a minor increment above minimal risk. So I think it might be useful to try to see what procedures we think might be considered a minor increment above minimal risk. And then a procedure that has substantial risk, though it's still a procedure we would allow to be performed in research. Okay, so everybody get their annotation tools ready, and we'll do this as as a group. So the first one is a 15 cc venous blood sample. So why don't you just mark in which column do you think is the risk level for this? All you have to do is put an X or a check. Less than minimal risk, minor increase above minimal risk, or substantial risk. What do we have for the first one?
It's substantial risk, I guess.
This is anonymous, so don't give it too much thought. Don't be afraid of getting it wrong. I just want to know your thoughts. So just mark in the column. Are you able to do that?
Sorry, I cannot find the annotation tool on the phone. I would put it 1.
Normally, it should be 5 cc venous blood sample. What I think with the 15 cc can be a substantial risk from clinical perspective.
All right. So on the first one, a lot of people are saying substantial risk, and some people are saying not more than minimal risk, and then we have someone saying a minor increase above minimal risk. Okay. 80 cc blood sample. A lot of people are saying 2 and 3. What about an arterial blood sample? Okay, now a lot of people are coming to life here. I was going to say maybe it's early in the morning, but no, it's in the afternoon for you guys. All right, so what about arterial blood sample? Who has the green check here?
Sosan?
Sosan. So you're saying that's minimal risk?
I think so, but I'm not sure.
Okay, all right. What do other people say?
I would say greater than minor.
Minor increment. Okay.
2.
All right. Other thoughts?
I would say 2.
I'm sorry?
I think it's 2. Greater
2.
than minor.
Okay. All right. Other is we have 8 people on this presentation. I'm not hearing many people.
I think it's greater than a minor increase above minimal risk.
You think it's okay?
Yes.
Oh,
Arterial blood sample.
Oh, I'm sorry. This should really be a minor increase above minimal risk. Sorry. Just a minor increase above minimal risk. I think that makes more sense. What about the lumbar puncture? Okay, minor increase. Minimal risk. Okay.
Substantial.
You hear some feedback here. What about a chest X-ray?
Less than or equal to minimal risk.
Less than or equal to minor.
Less than or equal to minimal risk.
Less than a minimal risk. Okay.
Yeah.
What do other people say?
Yeah.
Minor increase above minimal risk.
Minor increase above that. Okay. What about a CT of the head?
1.
I think this is
Less than.
greater than a minor risk.
Less than.
Less than.
CT of the head is what? Minimal risk?
Greater than
Less
minimal risk.
than. Less than.
Greater than minimal risk.
I'm
Less than.
sorry? Less than
Greater
or
than.
a CT. What about an angiogram with dye contrast?
Substantial risk.
I'm
3.
sorry?
3.
3. Okay.
Substantially, yeah.
I think, all right, what about a liver biopsy?
Substantial.
It's substantial.
Substantial.
All right, I think just want to get. All right, so this is substantial experimental drug given in a phase 1.
1. Less than.
1, minimal risk.
Greater than minimal risk.
Greater than minimal risk. Substantial. Someone said substantial. Colonoscopy.
1. Less than.
1, minimal risk.
Yeah.
No, 2.
Okay,
I think
someone
2.
said minimal risk. Colonoscopy is a minimal risk. Obviously, whoever said that hasn't gone through a colonoscopy, probably.
Actually,
2
I
and a
did.
half.
What's that?
2.
2 and a half.
All right,
It's 2.
it's 2. All right, so what? So what's the? After going through this exercise, what is the? How do you think we as a group are consistent in rating the risk levels of these procedures?
We are not consistent.
You're not consistent. Okay.
We should have objective way.
Objective way. All right. Well, how could you achieve that?
Putting criteria
Rating
for
criteria.
risk
Okay.
evaluation.
What about if you just have a list of procedures and you all have a consensus conference and rate what do you think what are the risk levels of these procedures? Which of these procedures are considered part of a routine physical exam? You go in and you have a routine, you have an annual checkup, or you come in and you have some minor symptoms. Which one of these procedures are considered part of routine examinations?
Venous blood sample.
Okay, blood sample.
Chest
What about
X-ray.
an
Chest X-ray?
arterial? What's that?
Chest X-ray.
X-ray.
Chest
Chest
X-ray.
X-ray.
Okay. Liver biopsy?
No.
No, you don't go in for a routine exam and come out.
I guess
with
none
liver
of them.
biopsy. What's that?
None of them equals the physical exam. Physical exam doesn't include interventions.
Oh, you go in for a routine checkup.
Routine checkup including investigations.
I'm not sure what you mean by investigations.
I mean samples, blood samples.
You come in for a routine checkup. I don't know if you have annual physical exams, but you come in and you just want to see how your engine is running. A routine checkup. I think what we're seeing here, a blood sample to look at your chemistries, your white count, maybe your lipid profile, chest X-ray. That's routine, but I don't think you come in for a routine physical exam and you get an arterial blood sample or a lumbar puncture or a CAT scan, or I mean, you get all this when you come in with unexpected symptoms, right? And so,
Yes.
I mean, I don't know what happens in your countries when you come in for a routine physical exam, but I think a chest X-ray and a venous blood sample is part of that. What's another procedure? Is part of routine physical exam?
Urine sample, stool
Oh,
sample.
okay, good. Urine sample, EKG, right? So now we'll get to why I'm talking about. Well, one part, as we'll see in just a few minutes, one part of a definition of minimal risk are risks not greater than those ordinarily performed in a routine physical exam. All right. So that's why I am marking these samples here. I mean these indications here. All right. Good. So let's let me get rid of all this. All right, so where's my? So I want to talk formally about minimal risk, and several of these slides. I want to thank Maha Imad for providing me with some of these slides. So today I would like to describe why it's important to define minimal risk and actually define minimal risk according to the regulations, at least in the U.S., and describe the different approaches to interpreting what minimal risk is. So what is risk? How do we define risk? Well, very simply, risk entails a probability and also a magnitude. I want you to think about that because we try to determine a balance between risk and benefits. Now, I haven't given you a formal lecture on how we do that, but balancing risk and benefits is probably one of the hardest things an ethics committee could do. You're balancing two different concepts here. We're balancing a benefit, which actually doesn't incorporate any sense of probability, whereas risk does incorporate a sense of probability. We don't call it harm, we call it a risk. And that just makes the whole enterprise of comparing risk and benefits just a little bit more difficult. So I wanted to make that clear. So why do we need to define minimal risk? When we review risks in a protocol, there's several things we need to do. One, we need to identify the risks, whether it's physical risk, social risk, psychological risk, economic risk, legal risks, okay? We have to define what are the risks in a protocol. Then we have to try to minimize the risk as much as possible. So instead of taking 80 cc's of blood, is it possible to do only 15 cc's of blood? instead. So we try to minimize the risk, and then we balance risk and benefits. But we never really need to define which procedures are minimal risks. However, having said that, we need to define minimal risk in order to determine the level of review. Now, I haven't formally gone over this, but in that protocol review form, you saw categories like exempt research, expedite research, and full board review. Without getting into too many details now, in order to determine whether a protocol meets exempt review or expedite review, one of the criteria is that the protocol needs to be minimal risk. And I think that makes sense. If you're going to have a protocol not go to the full board research ethics committee, it makes sense that at the very least, the protocol should be minimal risk, or no more than minimal risk. So we use a definition of minimal risk to determine the level of review. Also, as we'll talk about in this session, in order to waive the consent or waive elements of the informed consent, one of the criteria, as I said before, needs to be minimal risk. So that's the other reason why we should have embrace a common concept of minimal risk. And then research in children, as we'll see when we go over the regulations in children, which types of research are permissible in children may depend on a concept of minimal risk. So again, we're not going to go into details about the level of review or the types of research in children in this session, but we will be talking about when we could waive the informed consent. And again, one of the criteria is that the research should not be more than minimal risk. So hence, it's important if we all get on the same page regarding the definition of minimal risk. Okay, so having said that, so what is minimal risk? How do we define minimal risk? So here's a definition. The probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life. Okay, it's a two-part definition. Or during the performance of routine physical or psychological exams or tests. Okay, so one, not greater than those ordinarily encountered in daily life, or during the performance of routine physical or psychological examinations or tests. Okay. So, question. What are some of the types, if the definition is hinged to routine risks in daily life, what are some of the routine risks we take on in daily life?
Having car accidents or falling down from a step?
Right. Well, as I see two people riding in cars, I think that a routine activity that we do is driving in cars, and we hope that that's considered minimal risk. If it was, I don't think we'd be doing it too often. So driving in cars. What else did you say, Golana? Climbing up the stairs?
No, I said falling from a stairs.
Well, I mean, I think you're saying that we go up the stairs,
Yes, we go up or we come
right?
down. Yes.
And
Yes.
how often do we fall down the stairs?
Not frequently.
Okay, good, right, and that's why we do it. It's a routine activity that we do, and it's the fact that we do it often. We consider that minimal risk. Driving
Yes.
is minimal risk. Going upstairs is minimal risk. What other activities that we do is associated with minimal risk in normal daily life?
Taking the lift.
What's that?
Taking the lift. Using the
elevator?
elevator. Yes.
Yes, right, okay. What about flying in airplanes?
That's not regular. That's quite rare. Yeah, maybe once or twice a year.
Okay, but is that minimal risk or?
It is also
probability
minimal
of
risk.
harm times the magnitude.
It's quite rare.
Right, but what about the magnitude? When there's a plane accident. Well, I think it's
very large.
Pretty substantial.
Yes, yes.
Okay. So, other activities.
Exercise?
Exercise. We go to the restaurants and hope they prepare the food okay.
Cycling.
Yes, right. So we do. I mean, obviously, there's a lot of routine activities in daily life, and we take on most, if not all, of those activities because it's minimal risk, not greater than minimal risk. Okay, and why do we take on these? Why do we tolerate these risks? This is not a trick question. Why do we tolerate these risks with no more than minimal risk?
Because we know that the likelihood of harm from them is very, very small.
Okay, right. But do we have any benefits from
Yes,
these
we
risks?
have to do them. Yes, we have to do them. You have to go to work. You have to go out.
Yes, right. So there's a benefit. So we tolerate these minimal risk activities that are greater than minimal risk. Again, we'll take on those activities as well if the benefits are proportional.
Are greater. Yeah.
Right. Yeah. Okay. So now, having said that, to have a definition of minimal risk are not greater than those ordinarily encountered in daily life, is that helpful? When we want to evaluate a research protocol, what do you think? Is that concept helpful?
Yes.
Okay, tell me why you say yes.
Because considering that these are ordinary in daily life, then we can have a scale and then rate them from very low one that we can tolerate, like a headache that we might have, but we can tolerate it because it goes away on its own. And then we can scale based on what are tolerable, for example, for 1 hour, 2 hour, and then we can have till the other end of the spectrum, the very, I mean, substantial ones, that we will be paralyzed, or we will have a broken leg or heart failure or something, and then we can have a scale.
Okay, that sounds reasonable. Could we transfer those concepts to the research activity?
I think, yes, we can.
Okay, how?
We can identify what are the harms and what is the likelihood of them happening, and then based on that scale, we can say we can scale the magnitude.
Okay, so I think you're on the right track in the sense that, well, driving in a car, the probability of something happening is low. Well, depending on which city you're in, I think the probability might be higher in Cairo. And the magnitude of the harm could be minor or could be great. And I guess you could transport that to the research activity. So, but I guess you would have to scale it. So how would you use this concept in trying to decide whether a pulmonary angiogram with contrast is a substantial risk? I guess you have to take the harms. I guess you have to group different harms in the same category. Like if you get an allergic reaction to the dye, and as you said, you would rate that harm to a harm in, I don't know, driving in a car in a busy city. So I do agree it's somewhat doable, though I think it might be difficult. Though it gives you, I guess it gives you a baseline if you consider the risks involved in daily life activities. If you think a research procedure is associated with a higher probability and a higher magnitude, I think one might be able to determine whether a risk is greater than minimal risk. But it's not going to be easy. So what about this other part of the definition? Performance or routine. I mean, research takes on, I mean, the risks are due to the procedures, right?
Yes.
So I think it does make sense to compare it. If you're doing a research procedure that's not part of routine physical or psychological exams or tests, then you could say it's greater than minimal risk. Now, what about research activities that involve social behavioral studies?
Excuse me?
What's that?
Couldn't hear.
I'm sorry?
I just
Could you
couldn't
please
hear.
repeat? Could you please repeat your question?
social behavioral research regarding surveys, questionnaires, observation. How does this definition help us out? When we do social behavioral research, the risks are not coming from physical risks, right?
Yes.
Yeah, but it could be psychological risk.
Okay. Psychological
It's like
risk.
the ordinary daily life.
I'm sorry?
I would consider it minimal risk because it's like the daily life activity.
Daily life activity.
Yes.
Okay, well, last week we reviewed a protocol, and I thought I heard that a lot of people thought that some of those questions were dealing with profound psychological risks.
Mm-hmm.
So now I do agree that a lot of social risks are commonly encountered in daily life. Actually, I think this part of the definition is quite helpful. We do perform routine psychological examinations on physical exams, and we ask several different types of questions, and so we could determine whether the risks of routine psychological examinations are somewhat similar to the questions being asked in a survey. So, like last week, we had some questions like, do you smoke? Water pipe smoking, blah blah blah, and I don't know. Don't you think when you take a social history on a routine exam, don't you ask those type of questions?
Yes, we do.
We do.
Do you think they're greater than minimal risks?
No.
Oh,
no.
Okay. All right, good. So just something to think about when you look at survey questions on social behavioral research. Are these somewhat questions similar to the type of questions we may ask on a routine psychological exam? And in fact, it says here routine physical or psychological exams. I think something that's being left out of this definition is a history. A routine history. What kind of questions do we ask on a routine history?
We ask what surgeries they had or what medications they used to take.
Do we also ask if they do any street drugs?
Yes.
Okay. So is that greater than minimal risk?
It depends how they can tolerate it. Or maybe I'm thinking about even domestic violence. If you ask such questions, maybe it caused distress.
Oh, okay. It probably most likely does, but is that part of a routine history?
Yeah, it's a part of routine history to ask about any special habits for the patient,
Right.
including smoking
Exactly.
or any drug take.
Right.
Mm-hmm.
So my point is, if we include the history as part of this definition, if we're trying to define minimal risk as part of a routine physical exam in history, if we ask those questions on history, yes, it may cause some psychological distress, okay? But but we ask it anyway because it's important. And I don't know how often you actually ask those questions because maybe we feel uncomfortable in asking those questions, but I don't think, I mean, it may cause some distress. I don't want to trivialize that possibility, but I think that's a baseline. Even though it may cause some distress, that's a baseline to consider that as being minimal risk. So something to think about when we start evaluating whether risks are minimal or not. Think about what we do routinely in the clinic. We ask all these types of sensitive questions about drug habits, other habits, sexual habits. I don't know. I don't know if you
Alcohol
have
consumption.
What's that?
Alcohol consumption.
Yeah, alcohol consumption. I don't know if you ask questions about extramarital sex, sexual activities, but my point is, we ask many sensitive questions, as we should, in a routine history. And all I'm trying to say is that, yes, we ask sensitive questions, but they are routinely performed. And those type of questions are considered minimal risk. So in social behavioral research, I will say right now that as biomedical people, we tend to overrate the degree of risks when we look at surveys and questionnaires. But if you think about what we do ordinarily in the clinic, I think we should tone down our concept of what is minimal risk or greater than minimal risk. Okay, good. So this definition is somewhat helpful, though. Oh, right. So we have in this definition, ordinarily encountered in daily life. Well, a question to ask, in whose daily life? Is it the daily life? Whose daily life are we talking about? Is it well, before I go on to
Normal,
that,
healthy person.
healthy persons. Okay, very good.
Yes.
What about what do other people think about that? Healthy persons. Let me go through these slides. Yeah.
The daily life of the patient or the participant.
Okay, so those are the two contenders. We have so the two contenders are we have healthy people. Oh, that's oh, right. Healthy people or people who has the illness. Which one?
Healthy.
Why healthy?
Because
Why should it
something
be
that
linked
is
to healthy
counted.
people? What's that?
Because something that we count as can have a little risk on a healthy person is not measurable is not equal to something that happens to the person who is ill. For example, if you want to take blood sample of people over 70, someone may, maybe he cannot walk properly, he uses walker. So if you want to ask him to go to a laboratory and have blood test, it may have risks for him, even a very simple routine blood test, but on a healthy person, it's a very routine, minimal risk. So I think it's different how we define it on whom.
Okay, all right. But on the other side of the coin, someone said we should define it relative to people with the illness. So essentially, if we're going to enroll patients with cancer, who said illness?
It's me, Maha.
Okay, so tell me more about your thinking on that. So essentially, if we enroll patients with cancer in a chemotherapy protocol, the risks they are exposed to routinely are greater, right? In their life,
Yes.
they're taking toxic medications. I think Kolana was saying a blood sample from an elderly person may have more risk. So why should we link it to the illness that the research participant would have? I mean, a lot of people say that, but why?
Because of the magnitude.
Because these are the participants. I think that the level of tolerance would be different. So it depends on the participants.
Level of tolerance.
I think the magnitude of the risk.
I'm sorry?
And also we should weigh the benefit and the risk.
All right. I mean, but
I mean, for healthy volunteer, if we are going to give drug to in a clinical trial or something, and this drug would have side effects, and we would determine. So if there is this drug is given to cancer patients, and we think there is benefit for them, it would differ from trying drug on healthy volunteer who might not be tolerating these side effects.
I mean, for sure, we're not going to get chemotherapy agents to a healthy volunteer, but on one hand, I agree with you. We would weigh risk with benefits, and a patient with cancer will undergo a lot of risks from the chemotherapy agents, but hopefully there'll be benefits. However, I'm not talking about how we weigh or balance risk and benefits. I'm talking about in trying to determine whether a research protocol could be categorized as being minimal risk. Now, I explained in a previous slide why we want to have a standard of minimal risk. It determines when we waive.
You're asking about standard measures for all the protocols?
Well, when we want to, we want to determine whether a protocol is minimal risk or not in order to see if we could waive the consent, if we could expedite the protocol, or it's useful in determining permissible research in children.
Doctor, I think it depends on the study type, the study subjects. That's why we have, when we are recruiting the subjects, they have all to have the same inclusion criteria, and so that the risk will be the same on all of them. Like we cannot say in healthy or illness people. It depends on our research and subjects we are including. So we will try as much as possible to uniform all of them, so that the exposure, the risk exposure will be same on them.
Okay, but I agree with that concept, but is that important in determining minimal risk of the protocol?
Okay, let me suggest another example. If we consider X-ray a minimal risk, because this is like something we can do during routine physical exam, but our study is on pregnant women, this would not be minimal risk, so it has to be linked to the participants, right?
No, I thought you were going to say the opposite. Now, you take a woman who's pregnant. We were talking about a patient with cancer. I do agree that a chest X-ray in a woman who's pregnant is high risk, and hence we should not consider the condition of the participant in determining whether the protocol is minimal risk or not. Same thing with patients with cancer. If we link the definition of minimal risk to the daily life of those individuals in the protocol, we're going to consider a lot of dangerous procedures as being minimal risk.
Then we cannot have that unified scale, I think, because everyone has different medical conditions, medical history.
Right. Good. That is that's the major point. So actually, we have two standards: the relative standard and the objective standard. If we link it to patients enrolled in the protocol, we have the relative standard. And depending on the protocol, we're going to have different concepts of minimal risk. If we link it to healthy individuals, that's more of an objective standard. Also, think about this. If we link it to the relative standard and say minimal risk should be defined according to the people enrolled in the protocol, what they ordinarily encounter in their daily lives, patients with cancer and other long-lasting illnesses undergo a lot more risky procedures than in routine physical exams. The definition of minimal risk is going to be different for every protocol. So if we want to determine whether to waive consent or expedite a protocol, and the criteria is based on a minimal risk standard, we may find ourselves expediting a lot of cancer protocols and other protocols that involves risky procedures if we link it to participant to the ordinarily daily life of people with the illness and not with healthy volunteers. Now, having said that, so the relative risk standard, when people daily lives, which people's daily life should serve as the baseline for determining when minimal risk are minimal. The relative risk standard categorized minimal risk as those risks that people enrolled in the study experience in their daily life, which is, we call it the relative standard, but again, it's going to be greater than minimal risk in the daily lives of healthy individuals. And so again, the problem with daily life is that we're dealing with patients with cancer. Also, the other concept, daily life of healthy individuals living in normal societal conditions. So what's the daily life risk of someone who lives in Syria? Would we call it minimal risk? Or pick your country that has a lot of violence. So the what I'm trying to, let me skip through here. So actually in South Africa, okay, they have a definition of minimal risk in their regulations, defines negligible or less than minimal risk is equal to the probability and magnitude of physical or psychological harm that is normally encountered in the daily lives of people in a stable society. So they actually say it has to be healthy individuals or daily lives of people in a stable society. So, you know, if you're going to link it to the daily, normal, routine daily life risks, if you go to a war zone, you know, call it Syria, southern Lebanon, what have you, those daily life risks are going to be greater than minimal risk. So the concept is that you want to link it to an objective standard, so that when you evaluate a protocol for whether you expedite it, or whether it's permissible in children, or whether you want to waive the consent, you really need to have an objective standard. Or the other concept is that each protocol will be consistently referred to a standard that is objective and not based on the protocol itself. So, questions about that? So, risk, probability of harm occurring as a result of participation in a research study, and we define minimal risk because it's based on the level of review, the possibility of waiving elements, and also in consideration of what is permissible in children. And we look at the average healthy, normal people in their routine lives and on physical and psychological examinations. And as I said before, I like to include the physical and the history, because again, we ask a lot of sensitive questions on the history, and you know, if we thought that a lot of people would break down, would have nervous breakdown, we would not routinely ask this. I like the example of the domestic violence, because the recommendation is that whether or not you suspect it, you should still ask that question, because it's not going to be very obvious when women are subject to domestic violence, and we are not considered as doing a complete history on a patient unless we ask their issues with domestic violence, drug habits, sexual habits. All those questions should be asked routinely because they're important. And again, if we thought that people would have emotional breakdown by asking those questions, we would not ask them routinely. So think about that as we continue to evaluate protocols, especially those social behavioral studies. Okay. All right.
That's
Good.
mean. So that's mean the risk, the minimal risk can be the magnitude of the minimal risk can increase with the illness people comparing to the healthy people, right?
I'm sorry. Say that again, Saucy.
So the magnitude of the minimal risk can increase with the illness people or the patient more than with the healthy people, right?
No, we should link minimal risk to healthy people. Am I understanding your question correctly?
I know I'm asking, like, if we have the minimal risk magnitude, is it higher in the patients, like the illness, the ill one, the participant in a case study, comparing to the healthy ones?
Well, people with illness undergo routinely more aggressive interventions. And that is true. However, a definition of minimal risk because of that should not be linked to people with illness, because then the definition of minimal risk would be a relative one, and it would then be higher. But if we're using the concept of minimal risk to know when to waive the consent or expedite a protocol, we don't want this definition of minimal risk to be floating around high and low. It should be more objective. We should be more consistent in when we want to expedite protocols or waive the consent. And so that's why we want an objective definition of minimal risk.
Excuse me, you mean that with the
Thank you.
Research with minimal risk, we can waive the consent for all of them?
What do you mean, all of them?
I previously asked the question about collecting data from the medical records. You told me then that we shall talk about this, the waiver, consent waiver.
Okay, well, let's talk about it.
Okay.
All right, since you asked, so let's talk about the waiver of consent. Okay. So by the end of this presentation, you should be able to describe the criteria for when we could waive the informed consent. Also, waive the informed consent in what I'm calling limited contact research. Also, there's criteria for waiving the consent in research in the emergency settings, because sometimes if we have a drug to treat stroke in the emergency settings, sometimes it would be important to give that drug very quickly, right, in a stroke situation, and patients are lacking capacity to give their own consent, and family members may not be around. So it may be permissible to waive consent in some research in the emergency settings, okay? And a major takeaway from this presentation is to determine this term practicableness, because that's one of the criteria to waive the consent in limited contact research. So let's move on. So the Nuremberg Code says the voluntary consent of the human subjects is absolutely essential. Okay, informed consent, respect for persons. Now, the Nuremberg Code, so according to the Nuremberg Code, it says it's absolutely essential. So based on the Nuremberg Code, we would not be able to waive the consent. Also, we would not be able to enroll people with mental illness or children in protocols because we can't get informed consent from those individuals. So actually, the Nuremberg Code was a code for healthy volunteers. And then afterwards, in the 50s, with the Helsinki document and other regulations, those codes were regulations for patients in order to when to enroll patients, and the major concept is respect for persons. And as I mentioned before in previous lectures, respect for persons meaning, well, we respect people by asking for their informed consent, and when we can't get informed consent, we ask surrogates, and we have other safeguards. Okay, so are there types of research in which we could do ethically without subject consent and without surrogate consent as well? What do you think? What type of research?
Emergency ones.
Okay, emergency ones. What about non-emergency ones?
The one I asked about, the medical records.
Okay, the medical records. All right, good. So, so we need some criteria for that. So we do have, when I say limited contact research, record research, observation research on large groups. That's, again, limited contact. And then we have research in the emergency setting. All right, good. So we have some broad categories, but not all medical record research is it permissible to waive the consent, and not all research in the emergency setting is it permissible to waive the consent. So we need to develop some criteria because on one hand, we do want to advance science. On the other hand, we still want to protect subject welfare and their rights. So think about this. Well, let me ask this question. If we're waiving the consent, is that going against patient rights?
A normal setting, yes.
Well, in any setting, we're going against their rights. I mean, in the last few days, I heard a lot of people say, well, it's against their rights. It's against patients' rights.
If it's for their protection, if for the protection of their lives, it's not against them.
Well, research is not done for direct benefits for patients. We do research for future patients. Now, if there happens to be some direct benefit for patients, then that's good. Now, in the emergency setting, one of the criteria will be whether there's a potential for direct benefit for the participant. That's in the emergency setting. But what about record research? Is there going to be direct benefit to the participant if we do record research? No. So, so what do you think about this concept of patient rights if we waive the consent in record research?
It's against their rights.
Yes, right. That's right. So should we even consider record research without their consent? What do other people think?
I don't get it really.
You don't. What do you mean?
If we are taking data from the medical records, what harm or risk could this cause to the patient?
Okay, that's a good question. But is it still going against their right?
I don't think so.
Going against the right of privacy.
Yes, they should have a right to know what will happen even to their data and the usage of the data or medical history for research.
All right, so Galana, you're saying, so what I think I'm hearing you saying is that for record research, we should not waive the consent.
Yes, we should ask it in advance in a general consent form.
Well,
that this record may be kept for 5 years and we will use it for research.
Well,
if they consent, that's fine.
Well, the fact of the matter is we don't ask in advance for the data. I mean, it's getting to the point where we ask for future research for tissue samples. But think about this. We have all this data that's been collected for the last 20 years, if not 30 years, okay? And there's some important research that we could do. And guess what? We never asked them if we could use their records for research. So what should we do?
If there is no harm to their privacy, or if nothing can be traced back to the patients, or I think that's fine then.
Oh, okay. But we're still invading their privacy.
If it is de-identified, we would not affect their privacy.
Oh, but we're still in, well, what do you mean we will not affect their privacy? We are invading their privacy.
I think it's for a greater benefit, for the benefit of society and citizens, so that we can accept that.
Okay, all right. So very good. So very good. So if there's important research, then we could invade their privacy. I mean, because that's what we're doing when we're looking at their records. That's private information that they never gave consent for another researcher to look at. They gave consent for the doctor to look at the records, but not for a researcher. So there is this concept that if it's for the advancement of science and if the harm to them is very minimal, right, then it is permissible to invade their privacy rights. Is that what I'm hearing? Is that making sense?
Yes.
Okay. All right. All right. So I mean, I don't want us to feel like we're bad people. We're violating rights, but we are. But it's a balancing. Okay. We're balancing their welfare, which we said minimal harm, and their rights. As I mentioned the other day, it's not a fundamental right. And then we want to advance science. Okay, good. We're getting some work done. So again, minimal risk and autonomy interest is negligible. That's another concept, that if we think their autonomy right is negligible compared to like a right to vote or a right for free speech, okay, that's not looking at their medical records. That's not the same order of magnitude as violating their voting rights. Okay, so that's the other way to think about that. So let me clear the board here. So let me, because I want you to do this exercise. So when we talk about waiving consent, there are three types of waiving of consent. Okay, we could, and we addressed this the other day. We could waive the documentation of consent and only get verbal consent. Okay, and we could waive maybe certain elements of the informed consent, like the purpose of the research, or we could waive the whole informed consent document. Okay, so documentation of informed consent, we would waive that again when there's no more than minimal risk, and we're doing procedures commonly performed in the clinic. And more importantly, the signature is the only way to identify the participant. So in those cases, we could get verbal consent, but we could waive the written consent. And that's useful in phone interview studies, internet studies, also, again, if having the signature is the only way to identify the participant, and there may be great legal repercussions due to a breach in confidentiality. And also, people are hesitant to sign documents, and that occurs in many cultures. Now, waiving elements of informed consent, okay, that's mainly, well, before I get into this, what kind of research studies would we want to do in which we want to waive certain elements of informed consent?
What about the surveys or the questionnaires that the participant completes either online or in paper? He fills the paper. Does that mean he consented, and we do not have the whole elements in the informed consent, written the confidentialities, the risks, the benefits, blah blah blah?
Well, actually, in a survey study, we have all those elements.
But it's not written in an informed consent. But does that he fills the questionnaire? This means that he consented.
Well, one, I maintain that in our so-called information document that we give participants,
It's a separate document?
it's a what?
It's separate from the survey? It's other document?
Well, when we ask people to participate in the survey, we give them information about the survey. We give them the purpose of the survey, the procedures, meaning the questions, the risks of the survey, potential benefits to participants, or maybe to themselves, how we respect their privacy by ensuring confidentiality, any contact information. So actually, in a survey study, we do give all the elements of informed consent. And they do consent. We don't ask the documentation, but we say, if you complete this survey, if you start this survey, that's your indication of consent, right?
Yeah.
So it's a whole package deal with survey.
Yeah.
We do give informed consent. Now, just to fast forward, when we do deception research and social behavioral research, in order to study behavior in daily life, sometimes it's necessary not to tell the participants the real purpose of the study. And so we could waive that element of informed consent. Now, getting back to the major thing, the waiver requirements, there are 4 criteria for a waiver. The research involves no more than minimal risk, okay? The waiver will not adversely affect their rights. And when I wrote these regulations, they didn't unpack or specify what they meant by adversely affect the rights. And that has been interpreted that we're not going against a major fundamental right. So in medical record research, we are invading their privacy, but it's a negligible infringement on their privacy right. However, but it has to be no more than minimal risk. Also, the research could not practically be carried out without the waiver, and also, when appropriate, subjects will be provided with additional information after participation. So in the next few minutes, I want to concentrate on this term practicably. Could not be practically carried out without the waiver. So what does practicably means? The research could not be practically carried out without the waiver. Let me skip this slide. I mentioned deception research, and these are the okay, so research no more than minimal risk. We already discussed about minimal risk. Whenever appropriate, the subjects will be provided with additional information, and essentially that depends on the type of research, deception research versus retrospective research. If you're doing deception research, participants should be debriefed after the research and essentially tell them what was the purpose of the research. With medical record research, it may be impracticable to contact everyone afterwards. If you're doing research on medical records, but for the last 10 years, it may not be appropriate to start contacting everyone to tell them they were in a research protocol. So we're left with this last criteria about practicableness, and there are obtaining informed consent might not be practical for the following reasons. One, there may be logistical reasons, okay? For example, it may be difficult to locate the participants for the last 10 years, okay? Also, in some research, especially in research with critically ill patients, you need to give the drug right away. This is almost similar to emergency research, and there may not be time enough to contact family members. Now, another important category is what I call practical reasons. It may not be practical for methodological reasons, meaning that to preserve the scientific integrity of the research, it may not be practical to get informed consent from everyone. So what kind of research would that be for scientific reasons?
I think it's like observational research, that if you tell the participant, they will change their reaction or what they are going to and how they want to go to answer.
Okay, good. All right. Other types of research?
The studies on child abuse.
I'm sorry?
On child abuse.
Child abuse. Okay, so we would weigh parental consent.
Yeah.
Yes, okay, good. All right, well, that's a good start. If we want to do research and calculate the true prevalence, we may need to have a complete sample size, and that's similar to the concept of consent bias. If we thought that in some types of minimal risk research, there may be selected participation leading to consent bias, that may go against the integrity of the research. So again, in waiving the informed consent, when we look at retrospective review, it may not be practical to locate the subjects. Also, we would make it minimal risk by de-identifying the data. And also, again, logistical reasons, methodological reasons. Now, let me say a few words about the emergency research. It's not just any research in the emergency setting, okay? The criteria has to be patients are in a life-threatening situation, and the current therapy is considered unsatisfactory or unproven, and obtaining consent is not feasible because patient is lacking capacity and family members are not around. And this is probably the most important thing. The proposed intervention holds the prospect of direct benefit to the participants. So if you're just evaluating a new procedure or measuring cytokines, measuring cytokines in patients is not going to be of any direct benefit to the participants. So if somebody wants to measure cytokines on an illness in the emergency setting, that doesn't qualify for a waiver of consent. Make sense? So patient has to be in a life-threatening situation, you can't obtain informed consent, current therapy is unsatisfactory or unproven, and the proposed intervention holds the prospect of direct benefit to the participants. Also, well, yeah, obtaining consent from a proxy is not possible. Also, if your patient happens to wake up, you need to get their informed consent. Also, before doing the research, you have to consult with the community. You have to let somebody know that you're doing this type of research. It has to be public disclosure prior and after the study completion, and there has to be an independent data monitoring committee. So examples, new technique for patients from cardiac arrest, new blood transfusion products for severely injured patients, and new therapies for stroke. So those are some of the common examples. So now that you have all this background information, you all have that case studies for waiver consent that I sent last night.
Yes.
The answer should be yes.
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 Okay.
Yes.
Good answer. Okay. All right, so let me put you in your breakout rooms. Why don't you work on those examples for about 10, 15 minutes, okay?
Okay.
All right, let me
Professor,
yes.
would you please put me and Sarah in the same breakout rooms, because we are together with one phone, because her phone
Who's
is
that? Sarah and who else?
Connection.
yeah, she lost her connection. She's with me, so
Who's
to
me?
share Maha.
Oh, okay. All right. I mean, all right.
Yeah, she's with me. We will use. Yeah, she's here.
Oh, I see. I got it. Good. Well, all right. So, very good. So, let me open up the rooms. All right. I see you too.
Thank you.
I recognize you. All right. Very good.